Welcome to Prism Rounds, the audio journal club where we break down one study at a time for ICU, ED, and pulmonary/critical care teams, physicians, trainees, nurses, pharmacists, and respiratory therapists. A quick note before we start, this episode is created using AI-generated voices. I originally made these episodes to support my own learning and review, and I'm sharing them publicly in case they're helpful to other busy clinicians and learners. Because the voices are synthetic, you may occasionally hear mispronunciations of medical terms, drug names, or author names. Thanks in advance for your patience. Everything you'll hear is for education only and not medical advice. Let's get into today's paper.
Welcome to Prism Rounds, the audio journal club, where we break down one important paper for ICU, pulmonary, and emergency clinicians, focusing on bedside translation.
In acute hypoxemic respiratory failure, high-flow nasal cannula did not reduce 28-day mortality versus standard oxygen, but modestly reduced intubation and improved early dyspnea and respiratory rate.
Yeah, that right there is the definitive bottom line. We are looking at the brand new NEJM article.
Right, high-flow or standard oxygen in acute hypoxemic respiratory failure.
Published just recently in March 2026. And, we really can't look at this paper in a vacuum.
No, definitely not. We also need to dig into the accompanying editorial, Rethinking High-Flow Oxygen in Acute Hypoxemic Respiratory Failure. That one is by Dr. Serpinedo.
Which is a fantastic read, by the way.
Yeah.
But let's ground this, right? Think about the patient you were going to admit from the ER at 2 a.m. tonight.
Oh, we all know that patient.
Exactly. Bilateral infiltrates, breathing, 35 times a minute, completely tachypneic, accessory muscles are just visibly firing.
They look terrible.
Right. You're standing at the foot of the bed in the intensive care unit, and you have to make an immediate physical interface decision. What are you putting on their face?
Well, you're looking at this standard non-rebreather mask hooked up to the flow meter on the wall. And then right next to it, you're looking at the high flow setup.
The one with the thick corrugated tubing?
Yeah, the tubing, the heated humidifier. It's an everyday choice.
We make this exact choice constantly. We dial up that flow on the high flow nasal cannula. We hear that loud hissing sound, and we walk away feeling like we actually intervened.
You do. You feel like you did something active.
But the whole point of this deep dive into the literature is that we need to know exactly what we are buying with that therapy. Are we altering the actual disease trajectory, or, are we just treating ourselves?
It's arguably the most common critical care scenario we face. I mean, acute hypoxemic respiratory failure drives a massive percentage of our daily workflow in the unit.
It's our bread and butter. And over the last decade, maybe 15 years, high flow has completely transformed.
It really has.
It went from this niche kind of physiological curiosity to a completely foundational frontline therapy. I mean, you walk into any modern unit right now, and those machines are just humming in half the rooms.
And clinicians gravitate toward it for a really obvious reason. When you place a patient on high flow, it visibly seems to work right there at the bedside.
It does. You watch the monitor, right?
Yeah, you watch the monitors, you watch the patient's face, and the respiratory rate often comes down within minutes. The paradoxical abdominal breathing might blunt just a bit.
Honestly, it has very strong I'm helping energy.
It absolutely has strong I'm helping energy. You feel like a fantastic physician when you turn that dial up to 60 liters and the patient gives you a little thumbs up.
But that right there leads to the serious tension at the center of our practice.
The clinical anxiety.
Right. When we see that patient look just a little bit more comfortable and their diaphoresis resolves slightly, the question is, are we actually helping them survive?
Exactly. Are we altering the systemic inflammatory cascade of their severe pneumonia?
Or are we just improving the hemodynamics of their work of breathing temporarily? Because those are two very different things.
Very different. We have a therapy that feels incredibly effective locally, right at the airway, but establishing its impact on hard, definitive systemic outcomes like actual 28-day mortality has been really complex.
Well, let me push you on this, because as an ICU community, I sometimes think we let our bedside comfort with high flow completely outpace the definitive evidence.
You think we jumped the gun?
I do. Did we adopt it universally simply because it made the patients look better when we walked by on morning rounds?
Well, we certainly adopted it rapidly, but the historical context kind of explains why we did that. If we trace the trajectory back, the initial spark that set the entire field on fire was the Florali trial.
Oh, Florali. That was back in, what, 2015?
Yeah, 2015.
I remember when Florali dropped. It felt like a massive paradigm shift in how we managed these non-intubated hypoxemic patients.
It was a total watershed moment for us. Florali suggested improved survival with high flow compared to standard oxygen. And, importantly, it suggested a benefit compared to non-invasive ventilation in a specific, highly hypoxemic subgroup.
Which ignited massive enthusiasm.
Right, because it offered this well-tolerated alternative to strapping a really tight, uncomfortable BiPAP mask onto a patient who's already distressed and claustrophobic.
Suddenly, high flow was the golden child of the ICU. We were putting everyone on it. But, science is rarely a straight line. The data shifted a bit after Florali, didn't it?
It definitely did. Subsequent randomized trials over the following years, along with several network meta-analyses, they showed much less consistent signals regarding an actual mortality benefit.
The survival advantage just wasn't replicating the way we wanted it to. Especially when we expanded the inclusion criteria or altered the trial environments, we started seeing flat mortality curves.
Right, and then, well, the COVID-19 pandemic arrived.
Which changed everything.
It fundamentally acted as a massive accelerator for non-invasive respiratory support, really out of sheer necessity.
We had units pushed to the absolute brink. I mean, we were facing critical ventilator shortages.
Exactly, and we had this massive influx of profoundly hypoxemic patients with severe, profound VQ mismatch.
In that kind of environment, the rapid, almost universal adoption of high-flow oxygen wasn't just some nuanced clinical choice. It was a logistical imperative.
We had to do it. It solidified its place as our foundational method to keep people off the limited mechanical ventilators we had left.
And even post-pandemic, we saw trials like Renovate, which showed high flow performing very similarly to non-invasive ventilation across broader phenotypes of acute respiratory failure.
So its utilization is completely cemented in our practice now. There's no going back.
But despite that cemented use, the definitive mortality question was still hanging over us.
Which brings us to the specific mission of the SO investigators.
Right. They weren't looking to reinvent the wheel here.
No, they wanted to test a simple, highly pragmatic question for the modern era. Does high-flow oxygen actually improve 28-day mortality against standard oxygen therapy in a large, modern, generalized ICU cohort?
No boutique phenotypes, just the absolute bread and butter of critical care.
Exactly.
Let's break down the architecture of this trial, because the scale alone really demands our attention. How did they structure this to get a definitive answer?
Well, it is a multi-center, randomized, open-label trial. It was conducted across 42 ICUs in France.
42. That multi-center footprint is crucial for external validity.
It is. They randomized 11,116 patients, and exactly 11,110 were included in the final intention-to-treat analysis.
That is a massive undertaking for a respiratory trial. I mean, doing anything with 1,000 patients in the ICU is incredibly hard.
It takes years of coordination.
So who exactly were these patients? Because if SO only enrolled peri-arrest catastrophic patients, the data doesn't really help me manage the steady decline I see on the medical floor. What were the specific inclusion criteria?
They targeted adult patients admitted to the ICU with acute hypoxemic respiratory failure. The physiological entry gates were pretty clear.
Okay, what were the numbers?
A respiratory rate greater than 25 breaths per minute, bilateral or unilateral pulmonary infiltrates on chest imaging, and a ratio of partial pressure of arterial oxygen to the fraction of inspired oxygen, the PF ratio of 200 or less.
No, wait, hold on a second. A PF ratio of 200 or less requires you to know the exact FiO2.
Right.
You cannot dial in an exact FiO2 on a standard non-rebreather mask hooked up to a flow meter on the wall. It's physically impossible to know exactly how much room air that patient is entraining around the mask.
It's notoriously difficult to measure.
So how did they standardize that for the inclusion criteria to get a precise PF ratio?
That is actually an excellent methodological detail. For the patients on non-rebreather masks prior to randomization, the trial estimated the FiO2 using a standardized validated formula.
Oh, they used a formula. What was it?
It's 0.03 times the oxygen flow in liters per minute plus 0.21.
Let's actually do the math on that for the listener. If a patient is on, say, 15 liters per minute on a non-rebreather.
Okay, so 15 times 0.03 is 0.45.
Plus the 0.21 for room air gives you an estimated FiO2 of 0.66. Or 66%.
Precisely. Now, is it perfectly accurate down to the decimal?
Definitely not.
No, the fit of the mask and the patient's own peak inspiratory flow rate will totally alter the room air entrainment. But it is a mathematically sound, reproducible way to standardize inclusion criteria in a pragmatic trial.
Without requiring every single patient to be on a closed ventilator circuit just to get enrolled, I appreciate that. They tackled the messy reality of standard oxygen delivery rather than pretending they could control it perfectly.
Exactly. So those are the inclusion gates.
What did the actual interventions look like once they were randomized?
Well, in the high-flow group, patients received oxygen through a heated humidifier and large-bore binasal prongs. The initial gas flow was set pretty aggressively, at 50 liters per minute or more.
And what about the oxygen titration itself?
The FiO2 was adjusted specifically to target SpO2 of 92 to 96%.
And the comparator arm, the standard oxygen group.
They received oxygen continuously through a non-rebreather mask with the oxygen flow set at 10 liters per minute or more.
And the target.
Importantly, the FiO2 was adjusted to maintain that exact same target SpO2 of 92 to 96%.
You know, this is real ICU workflow. This is not a boutique physiology study done in a single room.
No, this is exactly what we do.
This is the exact titration parameter our respiratory therapists use every single shift. Keep them between 92 and 96.
It heavily grounds the trial in bedside reality.
So the primary endpoint they were powering this massive apparatus for was death from any cause at 28 days.
Yes, 28-day all-cause mortality.
And what were they looking at secondarily? Because we know mortality is a very, very high bar for a non-invasive interface.
Secondary endpoints included endotracheal intubation within 28 days. Also the time from randomization to intubation and the number of ventilator-free days at day 28.
Did they capture any early relief metrics?
They did. They captured early physiological metrics, specifically respiratory rate and dyspnea scores at the 1-hour mark.
I have to challenge the open label design here, though, especially regarding that secondary intubation endpoint.
You're worried at the bias.
You simply cannot blind a patient or a clinician to whether they are wearing a high-flow cannula at 60 liters or a standard non-rebreather mask.
Right. It is physically obvious from the hallway. You can hear the machine from the nurse's station.
Exactly. So if the clinician making the call to intubate knows exactly which device the patient is on, doesn't that introduce a massive systemic bias?
How so?
Well, a clinician might have a lower threshold to intubate the non-rebreather patient because they feel they haven't really maximized non-invasive support, whereas they might let the high-flow patient ride it out a little longer because they feel like they're doing everything possible. Can we actually trust the intubation numbers?
It's a completely valid critique.
Yeah.
It applies to basically any open-label respiratory trial. Intubation is not an objective blood lab.
It's an attending's decision.
Right. It retains a heavy element of subjective clinical judgment. However, the SOO3 investigators anticipated this exact bias.
So how did they control for the clinician's threshold?
To mitigate that bias, they mandated strictly pre-specified criteria for endotracheal intubation across all 42 centers. You couldn't just tube the patient because they looked tired.
What were the specific guardrails then?
They defined severe respiratory failure leading to intubation using hard physiological triggers. For example, it required recurrent episodes of SpO2 less than 80% or persistently less than 88% despite maximal support.
So profound refractory hypoxemia was one hard trigger. What about work of breathing?
They required documented signs of severe respiratory muscle fatigue or hemodynamic instability requiring vasopressors or a deteriorating neurologic status with a plunging Glasgow coma scale. Having these objective guardrails helps ensure that the decision to intubate is driven by real physiological failure.
Not just the attending's preference for one piece of plastic over another.
Exactly. It doesn't eliminate the bias entirely. I mean, we are human after all, but it certainly puts a solid objective fence around it. Let's pivot to the population itself. Who exactly were we treating in SOHO? The demographic breakdown paints a very clear picture of a standard modern ICU cohort. The mean age was right in the early 60s.
Okay.
It was a predominantly male population, roughly 73% in the high-flow group and 66% in the standard group.
What was the primary pathology driving the hypoxemic failure? Was this an ARDS-heavy cohort? A lot of trauma?
No, it was overwhelmingly a pneumonia cohort. Approximately 88% of the patients were admitted specifically for pneumonia.
Let's break that down further. Are we talking classic bacterial lobar pneumonia or viral pneumonitis?
It was both, but with a significant viral lean. About 53% had viral pneumonia. And given the trial ran from 2021 through 2024, the primary viral pathogen was inevitably COVID-19.
Right, the dates make that unavoidable.
Bacterial pneumonia accounted for about 32% of the cohort.
And what about the immune status of these patients?
It's really important to note that about 22% of the overall cohort was immunocompromised.
Oh, wow. Almost a quarter.
Yeah, so this wasn't just healthy adults with community-acquired pneumococcal pneumonia. It included a complex, highly vulnerable subset of patients.
How deranged was their gas exchange when they enrolled? You mentioned earlier the inclusion criteria was a PF ratio of 200 or less, but what was the actual mean? Did they barely scrape in at 199, or were they profoundly hypoxic?
The mean PF ratio was approximately 132.
That is low. 132. Let's contextualize that for the listener.
It's quite severe.
A PF of 132 places these patients firmly in the moderate ARDS territory by classic Berlin definitions, assuming they had bilateral opacities and the required PP, which, high flow partially provides.
They were sick, without a doubt. But it was a mixed severity group. Not every single patient was on the absolute brink of cardiopulmonary collapse the moment they were randomized.
So there was a spread.
Yes, only about 17% had a PF ratio of 100 or less.
That mixed severity is exactly what I want to highlight here. This is not a trial exclusively looking at catastrophic peri-arrest hypoxemia where the patient is basically agonal.
Right, it's not the extremes.
This represents a broad, generalizable population. These are the exact phenotypes of patients you are admitting from the floor or the ER on your next shift. The patient with an escalating oxygen requirement, breathing 30 times a minute, who hasn't totally declared their clinical trajectory yet.
Precisely. The baseline characteristics make the subsequent results highly applicable to our daily rounds. Which brings us to the primary result.
The hard truth about 28-day mortality.
Exactly.
Okay, lay the numbers on us. What did they find when they tracked these patients out to nearly a month?
Mortality at 28 days was exactly 14.6% of the high-flow group.
Okay.
And exactly 14.6% in the standard oxygen group.
Wait, exactly the same.
The absolute difference was negative 0.05 percentage points. The p-value was 0.98.
That is a clean negative mortality trial. You do not see survival curves lay on top of each other. That perfectly in critical care very often.
No, you really do not. If you open this paper hoping for a definitive survival win to justify universal high-flow use, the data simply does not give you one.
The lines are just flat against each other.
The lines are essentially identical from day 0 to day 28.
Let's spend some time unpacking what a negative trial really means in this physiological context, because the nuances here are critical. Does this mean high flow is a useless therapy and we should just throw all the machines in the storage closet?
Absolutely not. It specifically means that for the outcome of all-cause mortality at 28 days, it did not outperform a standard non-rebreather mask.
And the investigators ran multiple sensitivity analyses to ensure this wasn't just a statistical fluke, right?
They did. They performed an adjusted analysis accounting for stratification variables and center effects, and there was still absolutely no difference.
What about the timeline? Maybe 28 days is just too early to see the effect. Did they look at mortality further out, where the downstream effects of, say, avoiding an ICU stay might finally become apparent?
They looked at mortality at the point of ICU discharge, mortality at hospital discharge, and mortality all the way out to day 90. Across every single one of those time points, there was no statistically significant difference between the two oxygen delivery strategies.
So mechanically, we have to let go of the idea that putting these specific patients on a high-flow nasal cannula is going to directly reverse their systemic disease process and save their lives compared to standard oxygen.
We do. And biologically, when you strip away the bedside enthusiasm we talked about earlier, that makes perfect physiological sense.
I use this analogy with the fellows when we discuss supportive care interfaces. Expecting a non-invasive oxygen delivery device to reverse profound systemic sepsis or severe multi-organ failure.
It's asking too much of the device.
Right, it's like putting premium gas in a car with a blown transmission.
That is a fantastic analogy.
At a certain point, the mode of oxygen delivery simply cannot alter the downstream mortality that is being driven by the sheer severity of the systemic inflammatory response.
No amount of flow changes that.
If a patient is developing profound vasoplegia, acute kidney injury, and coagulopathy from a massive viral pneumonitis, flushing their anatomical dead space with 60 liters of gas isn't going to fix the endothelial damage.
Exactly. The therapy treats the proximal symptoms of hypoxemia and increased work of breathing, but it does not treat the underlying cellular pathology driving the mortality.
So the primary outcome is a wash. But here's where it gets highly relevant for our daily practice. Let's examine the secondary results, because I think this is where the actual bedside utility of this therapy is proven.
The most crucial secondary finding revolves around the intubation cascade.
Let's hear the rates.
The incidence of endotracheal intubation by day 28 was 42.4% with high-flow oxygen versus 48.4% with standard oxygen.
Let me repeat those numbers clearly for everyone listening. 42.4% versus 48.4%. That is an absolute reduction of roughly 6 percentage points.
Yeah.
That is not a trivial reduction. If you can spare 6 out of every 100 severely hypoxemic patients from getting a breathing tube, that is a massive clinical victory for those individuals and for the unit's resource management.
It is a profound, absolute risk reduction. But we have to be careful. Whenever we see a reduction in intubation in an open-label trial, we have to look incredibly closely at the timing of those intubations.
Right, to ensure the victory is real and not just an artifact of the clinicians hesitating to intubate the high-flow group.
Exactly. Because if they just waited longer to tube the high-flow patients because they, quote-unquote, looked a little better, the absolute numbers might be slightly lower, but the physiological damage of waiting could be severe.
So what was the timing?
The median time from randomization to intubation was incredibly similar between the two groups. It was 24 hours in the high-flow group and 23 hours in the standard oxygen group.
Yeah. I want to really dig into why that specific time metric is so vital. We talk about it constantly on rounds.
I cannot emphasize enough why this is arguably the most important secondary finding of the entire SOA trial.
Since the rapid adoption of high flow, there has always been this lingering, pervasive fear that the device merely masks clinical deterioration.
The dreaded delayed intubation scenario.
Right. The worry is that you put the patient on 60 liters and 100% FiO2, their pulse oximeter reads 93%, they look reasonably comfortable, so you walk away.
You feel like you've stabilized them.
But underneath that interface, their lung compliance is steadily plummeting and their transpulmonary pressures are dangerously high.
Exactly. You end up basically kicking the can down the road. You delay an inevitable intubation until the patient is in a much worse physiological state.
They're exhausted.
They are exhausted, their right ventricle is strained, and when you finally push the induction meds, they just crash hemodynamically.
Yeah.
This phenomenon is deeply tied to the concept of patient self-inflicted lung injury, or PSLE.
PSLE is such a critical concept. It's the idea that strong, spontaneous inspiratory efforts against non-compliant lungs generate massive negative pleural pressures.
Which then exacerbate pulmonary edema and alveolar damage.
Yeah, and if high flow was simply masking PSLE and delaying the inevitable, the median time to intubation would be significantly longer in the high flow group.
We would see intubations clustering at day 3 or 4 instead of day 1.
But we didn't see that.
We didn't. The fact that the median time is almost identical, 24 hours versus 23 hours, proves that on a population level, high flow isn't just delaying the inevitable.
It's actually preventing it.
It proves that high flow is actually preventing the need for the tube entirely in a distinct subset of patients.
Yeah.
It alters the trajectory for those who can be saved from mechanical ventilation.
Without dangerously prolonging the trial of non-invasive support for those who are rapidly failing.
That is a critical distinction. It's a true avoidance, not just a deferral.
Let's look at the immediate physiological data to understand exactly how it's achieving that avoidance. They measured respiratory metrics at the 1-hour mark, and the mechanism becomes very clear.
At exactly 1 hour after starting treatment, the high-flow group had significantly lower respiratory rates, an average of 26 breaths per minute compared to 29 in the standard oxygen group.
And what about their gas clearance?
Their PaSO2 levels were slightly lower, indicating better ventilation. And critically, their patient-perceived dyspnea scores were significantly improved.
So after just 60 minutes, they were breathing slower, clearing carbon dioxide more effectively, and physically reporting that they felt less short of breath.
Yes.
But what about their actual oxygenation? Did the high-flow group have higher PO2 levels?
This is the truly fascinating part of the physiological analysis. The pure oxygenation metrics, the actual measured PaO2 in the arterial blood gas, were numerically lower at 1 hour in the high-flow group compared to the standard group.
Let's break this down because to a junior clinician, this seems completely counterintuitive.
It does.
They are on high-flow oxygen, but their actual blood oxygen tension is a bit lower than the group on the standard wall mask. Yet they feel better and are breathing slower. Explain the physics of how that works.
It proves that high flow is fundamentally a flow matching and work of breathing therapy. It is not just a pure oxygenation therapy.
Standard non-rebreather masks can theoretically deliver a very high fraction of inspired oxygen, right?
Yes, sometimes pushing the absolute PaO2 quite high if the patient is pulling perfectly from the reservoir bag.
Yeah, right.
But standard masks do absolutely nothing to help the patient physically pull that gas into their lungs.
Right. If you have a patient breathing 35 times a minute with a peak inspiratory flow demand of 40 or 50 liters per minute, and the wall flow meter is only giving them 15 liters, they are sucking against a massive deficit.
It is utterly exhausting for them. They're doing all the mechanical work.
Exactly. High flow, however, actively delivers heated, humidified gas at 50 to 60 liters per minute.
That massive continuous flow matches or even exceeds the patient's own peak inspiratory flow demand. The patient doesn't have to work to pull the gas from the tubing. It is delivered right to the nasopharynx.
And then there is the dead space washout, which is incredibly elegant physiology.
The anatomical reservoir of the nasopharynx normally holds exhaled carbon dioxide at the end of every breath. High flow acts like a continuous flush system.
It just clears it all out.
Right. It washes out that anatomical dead space so the very next breath the patient takes is completely full of fresh gas. That drastically improves ventilatory efficiency.
And we can't forget the PEEP effect.
No, we can't. At high flows, especially with the mouth closed, the device generates a small amount of positive end expiratory pressure, roughly 3 to 5 centimeters of water.
It's not the 10 or 15 of PEEP you get on a mechanical ventilator.
But it is enough to stent open upper airways and perhaps recruit a few microidolactatic alveoli, preventing dynamic airway collapse during those strong inspiratory efforts.
All of those factors combined, the flow matching, the dead space washout, the modest PEEP, they drastically reduce the sheer mechanical work of breathing.
The diaphragm and the accessory muscles simply don't have to generate as much force.
And that is exactly why the dyspnea scores improve so dramatically at 1 hour. The physiological cost of breathing just plummets.
So even if the absolute PaO2 in the blood is a few millimeters of mercury lower because the FA2 titration was tighter, the patient feels infinitely better.
The patient doesn't care about the exact PaO2 number on their blood gas. They care whether they feel like they are suffocating.
And ultimately, they care whether they got the tube.
Which perfectly transitions us into Dr. Serponeto's accompanying editorial, Rethinking High-Flow Oxygen. This editorial is a brilliant philosophical challenge to how we evaluate respiratory support in the ICU.
Serponeto effectively deconstructs the entire paradigm of our trial designs. He acknowledges that 28-day mortality is the absolute gold standard endpoint in critical care.
We all want to save lives. That's why we do this job.
But he asks a very pointed question. Is mortality the right endpoint for this specific intervention?
He argues forcefully that we have to align the biological mechanism of the tool with the outcome we are powering the trial to measure.
Let's explore that alignment.
Sure. If you look at high flow's actual mechanisms, which we just detailed, reducing inspiratory effort, washing out dead space, providing low-level PEEP, and optimizing physical comfort.
Those specific actions are proximally linked to avoiding respiratory muscle fatigue.
Right. And avoiding respiratory muscle fatigue is proximally linked to avoiding intubation.
The proximal outcome versus the distal outcome.
Exactly. The immediate proximal effect of the cannula is that the diaphragm doesn't tire out, so we don't need to paralyze them and put them on a ventilator.
But whether that patient survives the next month, the distal outcome, depends on 100 other things. Their kidney function, their right ventricular function, their underlying immune system.
The virulence of the pathogen itself.
Exactly. Serponeto writes that expecting a substantial independent mortality reduction from a simple oxygen delivery interface sets an unrealistic and, frankly, unscientific benchmark for success.
It ignores the massive complexity of critical illness.
It does.
Okay, I agree entirely with the physiological logic of his argument, but let me play the role of the skeptical trialist for a moment.
Go for it.
Intubation is still a softer, clinician-mediated endpoint than death. Death is a binary. You are either alive at day 28 or you are not. It is undeniable and totally immune to observer bias.
True.
Intubation, even with strict criteria, involves human judgment calls.
That is the essential friction in modern critical care trial design.
Are we setting an unrealistic benchmark by demanding mortality wins for supportive care? Or conversely, are we just settling for softer endpoints like intubation avoidance because it's simply too hard and too expensive to prove a definitive survival benefit with thousands of patients?
It is a phenomenal debate. Yes, intubation is a softer endpoint from a statistical purity standpoint, but softer does not mean clinically unimportant.
Not at all.
Just because a metric involves the attending physician's clinical judgment doesn't mean it lacks profound significance for the patient.
Exactly.
If we rigidly only value interventions that show a stark 28-day mortality benefit, we risk discarding dozens of therapies that massively improve the trajectory of illness, preserve organ function, and improve the human experience in the ICU.
So let's translate this directly to the bedside. Let's walk the listener through the visceral physiological reality of why avoiding intubation matters so much.
Because it really does.
Because to someone who hasn't managed a crashing hypoxemic patient, a ventilator might just seem like a helpful, benign breathing machine that lets the patient rest.
The cascade of events that follows the decision to intubate is profound, and it is fraught with danger. Mechanical ventilation is a life-saving intervention, yes, but it is absolutely not benign.
Not even close. Let's trace the intubation cascade minute by minute. You decide the patient on high flow has failed. They are breathing 40 times a minute. Their gas is terrible. The first thing you do is push induction medications.
Usually powerful sedatives like propofol and paralytics like rocuronium.
That moment of induction is incredibly perilous. You immediately abolish their innate airway protection, but more importantly, you abolish their sympathetic drive.
In a patient who is wildly tachypneic and hypoxemic, their endogenous catecholamines are the only thing maintaining their vascular tone and cardiac output.
When you push the propofol, that sympathetic tone vanishes instantly. The vasodilation is profound.
And then the moment the tube goes in and you initiate positive pressure ventilation, you completely reverse their intrathoracic dynamics.
Let's explain that. They go from pulling massive negative intrathoracic pressures, which augments venous return to the right heart,
to suddenly having positive pressure pushed into their chest. This spikes right ventricular afterload while simultaneously obliterating right ventricular preload.
The hemodynamic stress of that transition is a highly vulnerable moment. The right ventricle simply cannot handle the sudden pressure shift, and the blood pressure plummets.
The SO trial actually tracked this specifically. About 10% of the intubated patients experienced severe arterial hypotension during the procedure requiring immediate vasopressor support.
And a smaller but significant percentage had cardiac arrest right there during induction.
And if they survive the intubation, the downstream cascade begins. Once the tube is secured, the patient is tethered to the machine.
We have to maintain heavy sedation, often with continuous infusions, just so they can tolerate the positive pressure.
This introduces a massive, undeniable risk for ICU delirium.
And as we know, delirium isn't just a temporary state of agitation. It correlates strongly with long-term cognitive impairment, increased length of stay, and higher post-discharge mortality.
Furthermore, by placing an endotracheal tube, you physically bypass the body's natural airway defenses, the gluteus and the mucociliary escalator.
You provide a direct highway for upper airway flora to reach the lower respiratory tract,
significantly increasing the risk of ventilator-associated pneumonia.
The trial data bore this out clearly. Almost 18% of the intubated patients in SOHO developed a secondary ventilator-associated pneumonia. You are adding a bacterial infection on top of their primary viral or bacterial pneumonitis.
And let's not forget the diaphragm.
Oh, the diaphragm. The pathophysiology of ventilator-induced diaphragmatic dysfunction is staggering.
When a machine takes over the work of breathing, the diaphragm, the primary respiratory muscle, begins to atrophy at a molecular level within hours.
Proteolysis begins almost immediately.
All of these factors, the initial hemodynamic collapse, the heavy sedation, the delirium, the secondary hospital-acquired infections, the rapid muscle weakness,
they conspire to drastically prolong the patient's stay in the ICU and complicate their eventual weaning process.
And stepping back from the pure physiology, it fundamentally alters the human experience of critical illness.
An awake patient on a high-flow cannula can nod to their family. They can point to a communication board to tell the nurse they are in pain.
They retain a crucial degree of autonomy and dignity.
An intubated patient is stripped of all of that. They are pharmacologically paralyzed, sedated, and entirely dependent on the care team for every physiological need.
So if we synthesize all of this, avoiding mechanical ventilation preserves functional outcomes. It massively improves the human experience of the illness.
It mitigates downstream iatrogenic complications.
And frankly, it saves an enormous amount of healthcare resources and ICU bed days.
Therefore, preventing an intubation is a major clinical victory, even if the 28-day mortality curve stays completely flat. If you spare 6 out of 100 severely ill people from that devastating cascade of complications, you've done something profoundly good for your patients.
That is the exact recalibration of our mindset that Serpinetto is calling for. We need to start valuing suffering avoided and complications averted as highly as we value death delayed.
Which brings us to the crucial topic of safety and bedside vigilance. Because if we are going to lean heavily on high flow to try and avoid the tube, we have to make absolutely certain we aren't doing silent harm while we wait for them to turn the corner.
The safety signals in the SOHO trial were very reassuring in this regard. They rigorously tracked adverse events occurring specifically during the spontaneous breathing phase on these devices.
Before any intubation occurred,
Right.
what were the absolute numbers for adverse events? Did the high flow rates cause excessive barotrauma?
Pneumothorax occurred in exactly 10 patients in the high flow group and 4 in the standard oxygen group.
And cardiac arrests?
Cardiac arrest leading to intubation occurred in 3 patients on high flow and 2 on standard oxygen.
So we are talking about exceptionally rare events overall, and crucially, there was no statistically significant difference between the two groups for either complication. The high flow doesn't appear to be popping lungs at a higher rate than standard oxygen.
Exactly. And we've already thoroughly discussed the historic fear that high flow masks deterioration and dangerously delays necessary intubation.
The fact that the median time to intubation was 24 hours versus 23 hours is the strongest objective evidence we have that this fear is largely unfounded.
When the therapy is used in a closely monitored setting with clear failure criteria.
But, and this is a massive caveat for the listener, that does not mean we can become complacent. The trial data is reassuring on a population level, but clinical vigilance at the individual bedside is non-negotiable.
High flow is not a set-it-and-forget-it therapy that you order from the computer and check on 6 hours later.
Absolutely not. If you walk away from the bedside thinking the patient is fine just because the SpO2 monitor on the wall reads 94%, you are missing the entire clinical picture.
Oxygen saturation is often the very last thing to drop before a patient arrests.
So what should the clinician be watching when they start a patient on high flow tonight? What are the subtle signs of failure?
You must watch the physical work of breathing. Is the respiratory rate trending up from 25 to 32 over 2 hours? Are they using accessory muscles, the sternocleidomastoids, the scalenes?
Are you seeing paradoxical abdominal movement indicating diaphragmatic fatigue?
You need to watch. The escalating FiO2 needs to maintain that target saturation. If you started them on 50% FiO2 to get an SpO2 of 94, and 2 hours later you are dialing it up to 80% to get that exact same SpO2, they are failing.
Regardless of how the pulse ox looks?
You also have to assess their mental status continuously. Are they becoming lethargic from CO2 retention? Are they getting agitated from tissue hypoxia?
And most importantly, you have to look at their dynamic trajectory over hours, not just single static points in time.
As we touched on earlier, do not get emotionally attached to the cannula.
It is so true. We do it all the time. But it's just a piece of plastic. It doesn't love you back, and it won't save a failing patient.
If the patient is declaring failure, you must escalate immediately.
The absolute worst thing you can do, and we see this in morbidity and mortality conferences, is let a patient exhaust themselves over 3 days on high flow, pulling massive negative pressures.
So that when you finally do push the induction meds to intubate them, they have 0 physiological reserve left and they arrest on induction.
Let's pivot and critically appraise the SOHO trial itself. No trial is perfect. What are its real methodological strengths, and where does it fall short in a way that should make us cautious?
The strengths are substantial. The large scale, over 1,100 patients, is impressive for a critical care respiratory trial. The highly pragmatic, real-world ICU population makes the results incredibly generalizable to our daily practice.
The use of excellent pre-specified intubation criteria mitigated a significant amount of the bias inherent in open-label designs.
And using standard oxygen via non-rebreather as the comparator was highly relevant because that is the actual binary choice we make at the bedside every day.
But what about the limitations? What should we view with a skeptical eye?
The most obvious is the open-label nature. We discussed how they tried to mitigate it, but no matter how strict the pre-specified criteria are, the final decision to push paralytics and intubate ultimately retains a degree of subjective clinical judgment.
You cannot physically blind the provider to the interface.
And what about the statistical power? We need to touch on the power problem because it plagues almost every modern ICU trial.
It is the classic statistical trap in critical care research. The SOHO trial was originally powered to detect a rather large 6% absolute difference in 28-day mortality.
The trialists designed the study expecting an 18% mortality rate in the standard oxygen group, and they hoped high flow would drop that to a 12% rate.
But the actual observed mortality in both groups ended up being exactly 14.6%.
Exactly. Because the overall baseline event rate, the actual mortality, was lower than anticipated, it drastically reduced the statistical power of the trial to confidently rule out smaller, yet potentially highly meaningful mortality effects.
Let's explain that dynamic. If you power a trial for a massive 6% difference, but the true benefit of the device is only a 2% survival benefit, your trial will show up as negative.
Because it simply didn't enroll enough thousands of patients to detect that smaller signal through the statistical noise.
Precisely. The beta error skyrockets. If there is a hidden 1 or 2% survival benefit to high flow, this trial, despite having 1,100 patients, simply wasn't large enough to find it.
We can say it doesn't cause a massive survival difference, but we can't definitively rule out a small one.
Here is a clinical question that I guarantee a lot of attendings will have. This trial took place heavily during the COVID era, from 2021 to 2024. Over 50% of the cohort had viral pneumonia.
Right.
Does the fact that this was a heavily viral COVID-driven population limit how we apply this data to a patient with classic dense bacterial lobar pneumonia today?
It is a vital question regarding external validity, and the authors explicitly acknowledge it in their discussion. However, they also point out that severe viral pathogens influenza, RSV, metapneumovirus independent of COVID-19 account for up to 60% of pneumonias that present with severe acute respiratory failure requiring ICU admission anyway.
So viral pneumonia isn't an anomaly, it's the standard.
Right. And more importantly, the underlying pathophysiology of severe VQ mismatch, increased dead space, and skyrocketing work of breathing is shared across many of these etiologies, whether bacterial or viral.
So while the specific pathogen mix heavily reflects the COVID era, the physiological principles of how the intervention reduces work of breathing remain completely sound and broadly applicable.
Completely sound.
So synthesizing everything we've discussed, the primary outcomes, the intubation avoidance, the physiological mechanisms, and the trial limitations. What is the core bedside directive for the clinician listening right now who is about to walk into the unit?
The core bedside directive is this. Continue utilizing high-flow nasal cannula early as a first-line non-invasive option for appropriate hypoxemic patients, but fundamentally change how you frame it in your clinical reasoning.
Do not frame it to families or to your colleagues on rounds as a mortality therapy. It is not a cure for systemic illness.
How should we frame it in our daily notes and our handoffs?
Frame it precisely for what it is. A trajectory tool, a work of breathing and comfort tool, a potent intubation avoidance tool, and commit to reassessing the patient constantly, looking for signs of fatigue.
Let's run through 2 rapid-fire contrast vignettes to really cement this bedside application.
Perfect. First vignette, the stable patient. You have a 62-year-old with community-acquired pneumonia. Their PF ratio is 140. They are attachmaic, breathing 28 times a minute, but they are fully awake, actively protecting their airway, and reporting significantly less dyspnea 1 hour after you start high flow at 50 liters and 60% FiO2.
In that scenario, keep going. The therapy is actively achieving its proximal physiological goals. The patient is comfortable, their work of breathing is manageable, their trajectory is stable, and you are successfully actively avoiding the devastating intubation cascade. Monitor their trajectory closely over the next shift, but stay the course.
Okay, second vignette, the failing patient. Same age, same pneumonia. But this patient is on maximum high flow settings, 60 liters of flow, 100% FiO2. Their respiratory rate is creeping up to 35.
You see increasing accessory muscle use, you see paradoxical abdominal breathing. They are profoundly diaphoretic.
And they are telling you in broken sentences that they are exhausted.
Do not delay the tube. Do not wait for their oxygen saturation to drop to 85%. The high-flow device has reached its absolute physiological limit. The patient is actively declaring failure and rapidly exhausting their cardiopulmonary reserves.
Escalate to intubation immediately in a controlled, planned fashion with good hemodynamics before they crash and turn it into an emergency airway.
Exactly.
All right, let's do a crisp, definitive recap of the final takeaways from the SOHO trial and Dr. Serpinato's editorial.
Number 1. There is absolutely no 28-day mortality benefit to high-flow nasal cannula versus standard oxygen in this broad, mixed-severity population.
Number 2. There is, however, a modest but highly meaningful reduction in the absolute need for endotracheal intubation, roughly 6%.
Number 3. High flow provides significantly better early comfort, rapidly reduces dyspnea, and improves early respiratory physiology like respiratory rate and work of breathing.
Number 4. Despite long-standing historical fears, there is no clear signal of harm from delayed intubation when these patients are monitored appropriately in an ICU setting. The median time to intubation was nearly identical.
And number 5, perhaps the most profound philosophical takeaway for our field. We must match our clinical endpoint expectations to the actual proven biological mechanism of the tool we are evaluating.
Which leaves us with a final, provocative thought to mull over on your drive home from the hospital. As critical care continues to evolve past the binary, crude goal of simply trying to keep patients alive at day 28, how will we design future trials?
How do we accurately, objectively, and statistically measure the suffering avoided by keeping a patient awake and off a ventilator?
And looking ahead to the next 5 years, could dynamic, real-time AI monitoring of a patient's breathing waveforms and inspiratory effort eventually tell us, within the first 30 minutes, exactly which patient is going to fail high flow?
Allowing us to individualize this therapy perfectly and avoid the guessing game entirely.
It raises a massive, important question about the future of personalized critical care, moving away from broad population averages to highly precise individual trajectory prediction.
It's the frontier of where we need to go as a specialty.
Thanks for joining Prism Rounds. See you next time.
Thank you for spending your time with Prism Rounds. If this episode helped you think through the paper or offered something practical for the bedside, I'd be grateful if you'd like, follow/subscribe, and share it with a colleague. It's the simplest way to help this resource reach other busy clinicians and learners. I'm also trying to make the podcast better with every episode. Please leave a comment with what you found most useful, what felt unclear or too long, and what topics or papers you'd like covered next. If there's anything I can do to improve pacing, structure, level of detail, or audio quality, I genuinely welcome the feedback. Thanks again for listening, and take care. Educational use only. This is not medical advice.